controlled by that sinus node, the sinoatrial node, SA node. You may hear it called any or all of those. Should something happen to that or something get blasted there or what do they call it, ablated there, then you're going to be dependent on the AV node and so forth. It's going to go on down the bundle of His, the Purkinje fibers. Each one has a set rate. Sinus node is going to be from 60 to 100. That's going to keep you at a normal sinus rhythm rate there. It's always going to be 60 to 100. If the control has to go down to the AV node, the atrioventricular node, then that's going to be a rate of 40 to 60. If something further happens and it has to go down to the bundle of His, it's a rate of less than 40. Purkinje fibers, the rate's going to be 20 or less. So obviously we want them to be up higher because that's going to be better control. We're going to have better rate, better cardiac output. So it begins with the sinus node. We're going to talk about waveforms. We're going to talk about the AV node, the bundle of His, and the Purkinje fibers. AV node is called the secondary pacemaker. The SA node is the heart's normal pacemaker. Sorry, I forgot to turn that off. I don't know what JCPenney wants, but they can wait. This is a nice little map of all of the intervals and segments and what they do. These are the things that you're going to be measuring. We'll start measuring later with our little pointy toys. If you have your own, that's fine. If not, I'll give you one from the lab. So this little section, the PR interval, even though it has to be that some ignorant dude named this, because it should be the PQ interval, but for whatever reason it's the PR interval. Anyway, this is the PR interval from the beginning of the P wave to where the QRS complex starts. And that represents atrial depolarization. Your heart is electrically based, so all of these have depolarized, repolarized, and so forth. QRS interval is this narrow complex right here and represents ventricular depolarization, and atrial repolarization is hidden in there because obviously the QRS is so big and wonky that it covers up the other action. There's your ST segment from the S to the T, and your T wave is ventricular repolarization. We will be measuring PR, QRS, and QT. These will all be things that you have to measure on your checkoff. P wave, each one of those blue arrows is representing a P wave. Obviously, we're not all Boy Scouts, so it's not all pretty. Sometimes they're there and sometimes they're not. Sometimes they're obvious and sometimes they're not. But a normal rhythm should always have a nice little P wave before the QRS. They should march out, so they should be equal. That's what it means when you march something out, that they should always be the same distance apart. The QRS complex is the tall bit in the middle. This just shows that there's multiple forms that it can take depending on what lead you're looking at the heart with. How many stickers and wires do they have on their chests? How many different angles are we looking at? Are they going to be tall? Are they going to be short? Are you only going to see the R? They can look just about any way they want to. But as long as they're there, right? We want the heartbeats. T wave is the Humpty Dump afterwards. It should always march out, just like the P wave, just like the QRS complexes. Everything should be at the same distance. If I turn my pages, that'd be useful, wouldn't it? Just took a life in my hands. My finger. That was stupid. Okay. Sometimes you see the U wave. Nice little, tiny little thing after the T wave. not always there, but if it is there, it's showing Purkinje fiber repolarization. Risks for dysrhythmias. Age. They can just be old and have more likelihood of dysrhythmias, because as we age, our normal pacemakers just do whatever the crap they want to. You develop all these extra branches. It just does whatever it feels like doing. Myocardial infarction, so that if they've had a heart attack, that can make the rhythm look funny. High blood pressure, heart valve disease, heart failure, drug use, med toxicities. Maybe they have sleep apnea, diabetes, they've got some wild infection happening. These are all considered risk factors for developing a dysrhythmia. But age is your primary risk factor. Fat deposits around the SA node can slow things down too. Some of your dysrhythmias are killers. Some are going to cause symptoms and some will be asymptomatic. Just find it on the EKG and go, I didn't know that was there. If they do have symptoms, it's going to be things like they feel like they're having palpitations, so they feel like their heart is racing, skipping a beat. You can have any number of things described. Patients will describe things in really strange ways sometimes. They might have low blood pressure, so hypotension. They might be sweaty, diaphoretic. Some dysrhythmias will cause shortness of breath, whether it's running too fast or too slow, they can't catch their breath. And they may pass out on you. They may faint, syncope, syncopal episodes. Excuse me. By now, I think you all have seen EKG strips. Yes? No? Maybe? In clinical? No? We've not seen? Not everybody? Okay. Well, there's special paper for it. And it always has all these lovely little lines, so you get cross-eyed looking at them. Fantastic. So you can see in this, and this is not the greatest picture, is it? There's heavier lines and lighter lines. And those heavier lines are in groups of 5. There's 5 little boxes. So here's your heavier line, and there's your smaller lines. These are 20ths of a second, 0.2 seconds for a big box. Okay? Each tiny box is 0.04 seconds. So we have to work in decimals. And this is usually what gets people messed up on EKGs, is the decimals. Try to remember the 0.04 and 0.2. That's crucial to measuring any rhythm. We're going to measure PR intervals, QRS intervals, and QT intervals. QT intervals don't get measured that often in practice, but there are some drugs that can cause those to be extended or shortened, and we don't want those messed with too much. So if they order you to measure the QT interval, then you will have to keep track of that. Just nice little heavy lined pictures, because, we need big lines. Gives us a PR interval to follow, a nice little tiny QRS, and the larger QT interval. I gotta remember to turn my pages. So our steps in interpreting an EKG is the rate fast? Is it slow? Is it normal? So we know that normal is 60 to 100, right? Anything below 60 is too slow. Anything above 100 is too fast, right? Now, there might be reasons for those. Maybe you're treating Michael Phelps for something, and he's an Olympic athlete, and his resting heart rate's 50. Okay. But we want to make sure we investigate it if it's below 60. Is it regular? Are there P waves there? Are there QRS waves there? And are there T waves there? Are all of those intervals that we just measured with our calipers, are they in normal limits? Is there a P wave before every QRS, and is there a QRS after every P wave? They have to pair up together. Otherwise, you've got something wonky. That's a technical term. Wonky. So we're going to calculate the heart rate and we're going to calculate regularity. Regularity is where we march it out. And counting is we're going to count how many. So there's these little notchy things on your EKG paper. Sometimes it's a line, sometimes it's a triangle like that. We measure in 6 seconds. So from triangle to triangle is 3, triangle to triangle is another 3. So we measure in 6 seconds. Any ideas why we do that? Because then we can multiply by 10, and that's easy. I like to multiply by 10. It makes nice round numbers. So we measure in 6-second strips, and we count how many QRS complexes are within that 6 seconds. So 1, 2, 3, 4, 5, 6. Heart rate's 60. Quick and dirty, right? Nice and easy. We're going to look for a P wave before every QRS. Every QRS is followed by a T. Everybody's all pretty and nice Boy Scout rhythm, right? Because we have patients who look like this, right? Right. Maybe. On a good day. So we march it out for regularity. We have the same distance. We don't have to change our calipers. Everything's perfect. Oh, happy. Okay, then we go down here. Oh, yikes. Uh-oh, screw that. Oh, everything's different, right? It's all irregular. There's P waves, there's QRS waves, all the bits are there, but it's not coming out in the way it's supposed to come out, right? We're not able to march it out because there's different lengths between that little run of beats there. This is the nice, perfect, normal sinus rhythm. Got a P wave, QRS, T, everything's hunky-dory. Marches out. Oh, so pretty. Lovely, right? Now, it's called sinus bradycardia if it's less than 60. Might be because they're hypoxic, might be because they're hypothermic. If it's dangerously low and they're having symptoms, then we're going to have to treat it. If it's just because they're an athlete, they're in excellent condition, maybe they run at 50 or 55 all the time. I tell you, those people will scare you when they go to sleep because their heart rate will be like 38, but they're fine. Anyway, makes me nervous. If you do have to treat it, you will use a drug called atropine. Atropine increases the heart rate immediately upon pushing it in there. It's going to increase your heart rate. And then to maintain that, you will have to use transcutaneous pacing until they can get to the cath lab to get a pacemaker. So it's going to be a lot more spread out. Still going to be regular. Still marches out. P waves are still before every QRS. We got a 6-second strip. 1, 2, 3, 4. So we got a heart rate of 40. Go check your patient if you get a heart rate of 40. They're probably just sleeping, but they might be suffering. If you do have to pace someone, you will be placing the AED pads on them or the defibrillator pads on them. It can be 2 ways. You can do both of them on the front, or you can sandwich them. One on the front, one on the back. Put the heart right in the middle. If they are a hairy ape, you may have to use 2 sets of pads. And that happens a lot around here. We get some hairy dudes out there. You may have to just wax them. They're not going to like it, but it's better than dead. Sorry about your luck. Should have gone with the spa. Sinus tachycardia. Rhythm rate. It's a rhythm with a rate greater than 100. They may have a fever. They might be anemic and their heart's having to work harder because it's having to push blood around, not enough blood around. They might be hypovolemic, maybe they've lost some blood, low blood pressure, they've thrown a pulmonary embolism, or they've had a heart attack. A billion other reasons. These are just the most common. Maybe they just had a breathing treatment and their albuterol sent their heart rate over 100. That's okay. But go check your patient if they've not been over 100 and now they suddenly are. If we have to treat the cause, we're going to treat the fever. We're going to treat whatever is causing it to go over 100. If it's a breathing treatment that just made it go over 100, you just have to wait it out. But if it's a long-term thing, they're going to get beta blocker drugs. They're going to get calcium channel blocker drugs. And that's going to help slow them down. Name some beta blockers. It's the Olol family, right? What about calcium channel blockers? The Peens? Peens, okay. All right. Those are important categories to know. They always show up on the NCLEX. Sinus tach, same as sinus rhythm. You're still going to be able to march everything out like clockwork. All your P waves are there. All your T waves are there. Everything marches out, regular as can be. It's just fast. So how many we got here? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. Heart rate's 130. Make sense? Yeah? No? Yeah? Maybe? Okay. Because now we get the funky ones. Atrial fibrillation is extremely common. It is one of the most common dysrhythmias that you will see. It does increase the risk of stroke because blood will pool in the atria while it's quivering. Then they switch back to normal sinus, and that clot goes straight to the brain through the carotids. There are no P waves that you can find. There's just quiver. That rate, that chaotic atrial rate will be going at anywhere from 300 to 600 beats per minute, so it's just like a little panic line there. Our causes are age, again, most common, age. Maybe they've got a big old floppy heart, cardiomyopathy. Maybe they've got an infection around the heart, pericarditis, thyroid disease, valve disease, high blood pressure, obesity, diabetes. We don't have any of that around here, do we? No. Chronic kidney disease. It is especially common if they have had open heart. If they get in there, they've split the sternum, and somebody has messed around with your heart, that messes with the electrical system, and it is very, very common after open heart surgery. Treatment for atrial fibrillation, we're going to want rate control because it's going to go crazy sometimes. So we may need digoxin to help slow the heart down, and we may need those beta blockers and calcium channel blockers. There's some other antiarrhythmic medications that may help. They may have to actually do an ablation or a cardioversion. Saw an aware cardioversion the other day. Whew, he was not happy. Jumped up and screamed lots of cuss words. So you can see it's just, it's a hot mess. Ugly. Nothing's regular about this. Well, there's nothing regular about that whatsoever. Now you can do a quick and dirty count on these on a 6-second strip. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17. So we're in the 170s. But if it is an irregular heart rate, you are expected, at least on your first assessment of your shift, to stand there for an entire minute and count the rhythm. Okay? That one's kind of fugly, isn't it? We're hanging out in the 50s. All right. Neither one of those is good. I don't like either one of those. This one's too slow and that one's too fast. You're going to see people that can't catch their breath. They're going to tell you they can't, they feel like they're having palpitations. They don't feel good. Supraventricular tachycardia. So this is tachycardia that starts above the ventricles. So there's some kind of random electrical spot that's taking taking your life in its hands and decides to just spit out some tachycardia. It's like, yep, we're just going to go with 250. It's fine. So we're going to treat the causes, and we're going to cardiovert. People can't stand a heart rate of 250 for very long. Marches out. But can anybody tell which part's the P wave, which part's the T wave? No. It's all smushed together right there, so you can't measure that, right? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 170. No thanks. You see this person convert into it. Oh, this was pretty. It was all nice, and then chaos. And again, you can't find your P wave, you can't find your T wave. All you can measure in this is a rate and a QRS. Okay? Premature ventricular contractions, so the ventricle just decides to just have its own thing. It's high on something or whatever. It's just feeling its oats, right? So it's going to just randomly have a pulse. It might be because they're hypoxic. It might be because they've had a heart attack. Maybe they've got a big floppy heart, cardiomyopathy, or they've got an electrolyte imbalance. Potassium, sodium, calcium, all of these make a difference in your heart. And we're going to correct the cause, and it might be often enough that they have to actually take something as an antiarrhythmic. And these are ugly. They can take any form they want to. They might all look alike because they're coming from the same spot. They might have, well, that one's coming from the north, that one's coming from the south. It just wants to do whatever it wants to. They might occur in couples. If it looks like this, those are called unifocal. They're coming from one focus, one place because they look exactly alike. Unifocal. These are coming from multiple foci, or however you want to say it, I don't care. So they're multifocal PVCs. Those ventricles are just dancing, having fun. You see 2 in a row, we got to start thinking this patient could easily have some trouble. Because when they're 2 in a row like that, it could easily become 3 in a row, become ventricular tachycardia. Life-threatening rhythms. So we want to take PVCs seriously as long as somebody has seen them. It's not necessarily something you're going to wake somebody up over at 2 a.m., but it's definitely something you want to transfer and report. Make sure that the doctor sees it and knows it's there, and that you've had an electrolyte panel to investigate it. At least how makes sense, ain't it? Because this becomes VTAC. When there's 3 in a row, it becomes a 3-beat run of non-sustained VTAC. This just shows a strip. Some places you'll have strips that show you 2 different views on the same strip. It gets kind of crowded, but they will sometimes show you 2 different views. So that one's looking at the heart from one direction. This is looking at it from the opposite direction. But they all look the same, don't they? So they're unifocal. Every 2 beats. You get 2 regular beats and then a whopper. 2 regular beats and then a whopper. Okay, that's called trigeminy. It's every 3rd beat. If it's every other beat like this, it's called bigeminy.
You said every 3 beats.
Every 3 beats, it's trigeminy. Every 2 beats, it's bigeminy. If, like that top strip, it becomes 3 strips in a row, you've got ventricular tachycardia. Some providers will want you to save all the strips, all the runs of VTAC. Some of them just want to know that there was one. They'll start treating it. Maybe they're hypovolemic, hypoxic, acidotic, 1,000 different things, but these are the most common. Potassium is affected, hypo or hyperkalemia. Maybe it's their sugar. Maybe they're having a heart attack or have thrown a pulmonary embolism. Cardiac tamponades, too much fluid is in the is in the sac around the heart, and it's impeding the function. So if they have a pulse when you get that ugly VTAC, then we're going to start with meds. We're going to replace electrolytes, and we might have to cardiovert them. So if they have a pulse, you're going to cardiovert. You're going to set that to sync so that it gets it at the right time. Because if that shock comes at the wrong time, you can actually kill them. So let's not kill them. If it is pulseless, you're going to start CPR. And then you will defibrillate. That's the difference. Cardioversion, they still have a pulse. Excuse me. Defibrillation, they dead. Okay, defibrillation, dead. Let's start some CPR and start the defibrillation process. That's when you're going to get your AED or your defibrillator. Ew. Now, sometimes this appears on the monitor and your patient's doing this, brushing their teeth. Okay, or shaking their face, or washing their arm, whatever. So go check your person, please, when you see this. Most likely, they're doing something, okay? Might not be something you want to walk in on. However, please go look at your person when you see this on the monitor. Because the monitor not only will be screaming, but we want to make sure that they're actually okay. It is lethal if that is a true rhythm. If we don't treat it, they will die. Even if they have a pulse when it first appears, nobody can maintain that rate for very long. Maybe they're hypoxic, they took off their oxygen. That never happens, right? They always leave their oxygen on like good little patients. No. Gonna go put the oxygen back on them. Maybe it's their potassium, maybe it's their sugar. We have to fix it. Once we get to ventricular fibrillation, we have to start chest compressions and defibrillating. Okay? And it doesn't have that nice look like a row of penguins standing in the Antarctic. It just looks like squat. That doesn't, no, we're going to start CPR and we're going to defibrillate. There's some kind of electrical activity, but it's absolute chaos. You can't measure anything about this. You can't measure a rate. There's no QRS complex. This is please defibrillate. Please start CPR. And this is everybody's favorite because it's the easiest one, right? They're really dead. Asystole. No activity whatsoever. Not even a peep. Now, does that flat line always mean that they're in asystole? No, sometimes they've just popped their leads off. Or Papa Bear had too much hair, and you got to go in there and put new stickers on him, shave a little spot, put new stickers on him. They've sweated them off. Maybe their fever just broke. So go check your person. If it's true, then start CPR, please. Because there's no electrical activity and defibrillation is useless. Now, if they already have a pacemaker, you're going to see these awesome little perfect straight lines. That's always your indicator of a pacemaker. And that's going to tell me my rate because I got me a 6-second strip. 1, 2, 3, 4, 5, 6, 7, 8. They're set at 80. Their heart rate's always going to be 80. It's so nice. When they're dependent on their pacemaker, you always know what their heart rate's going to be. It's like people that always record a respiratory rate of 16. You can always record a rate of 80 when they're pacemaker dependent. You will always have those little spikies. It can be on demand and it can be dependent. It might just be on their atria, it might just be on their ventricle, it might be both. So you may see two little spikies, one for the P wave and one for the QRS. They may also have a straight line there, a nice little pacer spike that's not followed by a beat. That's a problem. We can't have that. That's called failure to capture. Okay? Lovely little spikes. Oh, they're so regular. And uh-oh. What happened there? We had a pacemaker fire, but the muscle didn't contract. That's a failure to capture. And that's a problem. That is something that you may have to wake somebody up over if the patient is symptomatic. If not, make sure that they know in report that they had some failure to capture. All of these lovely beasts, this is a dual chamber. Dual chamber pacemaker, and they are pacemaker dependent because every single beat comes with a spike. Can you still measure things? Yeah, you can still measure things. 1, 2, 3, 4, 5, 6, 7. We're set at 70, right? You can still measure a PR interval between the two spikes. Your QRS is going to be, it's going to be weird, wonky. QT is going to be strange. But at least they've got a heartbeat, right? Heartbeat good. No heartbeat bad. Okay? That top one is just a spike for the PR. Okay? This one usually gets people on the checkoff, is the pacemaker. What do I need to know from the pacemaker strip? If you have a pacemaker strip on your checkoff, which of course you all will, I need to know if they are dependent on it. I need to know that it is 100% capture or if there's a failure to capture. Okay? I need to know that you can still measure these. Are they going to be within normal limits? Probably not, but they've got a pacemaker. Not exactly a normal heart, right? But if you see this one, then I need you to record failure to capture. Okay? Do those make sense? Yes, no, maybe.
Yeah.
Yeah? The numbers are the hardest part, is to get the numbers in the normal, within normal rhythm, or within normal limits. This checkoff will not be until October 24th. Okay, it was originally set for the 17th, but we realized that didn't give you guys a whole lot of time to practice because of fall break, and we won't necessarily be in here on fall break to help you. So we want to give everybody plenty of time to get to the lab and practice. I know these have chapters and figure numbers on them. It's from the EKG book. You can ignore that. Yes, dear.
Okay, so your information is from the EKG book?
It's from the first one was from the F.A. Davis book that we don't use anymore. But it's all the same. All the numbers are standardized. And these are from the EKG book, but you guys don't have it. These are just examples so that we can practice together. You guys can look at them, and we can practice the ones that you're going to check off on. Because it's not near as many as you used to have to check off on. You used to have to check off on all the heart blocks and all the junctional rhythms and all that. And they finally decided, it's too many.
So how do we study for your exam since we don't have the book that we use?
My PowerPoint.
Just your PowerPoint is all we need.
Hey,
Is there anything extra?
No, I test for my PowerPoints. If you want to look at an
even this
EKG
book
book,
right here, as old as it is, it's probably older than maybe some of y'all here.
it's still universal.
It still has the same numbers
Just
as
to
what
keep
she's
us
saying.
from buying more books to run.
Yeah, you don't have to. No, there's a site somewhere. Somebody had it a few years ago that you can like test yourself on and look at different strips. But I just don't. I don't always like those because they have some of those wonky ones thrown in there that we're not doing. And I'm trying not to overload anybody. There's 10 rhythms and that's it. Okay? 10 rhythms is all you have to check off on. And it used to be like 25, so yeah. And we used to check off on the same day, but too many people had kittens, so we don't do that. Okay. So we're going to identify the rhythm. What are we going to do first?
Look for your.
We're going to count it, right? Because it's a 6-second strip. That's what these lines are, right? 1 second, 2 second, 3, 4, 5, 6 seconds. Is this a whole complex? Can we count it? No. 1, 2, 3, 4, 5. Okay? So our quick and dirty count is 50. What else are we going to measure?
The P
Regularity. I heard regularity. P waves. P waves. G waves. Woo! Nice and pretty. And it should be the same distance. Okay? That's all perfect. So now what? What else are we going to measure?
Your QRS.
The QRS. What about the QRS? The intervals like the regularity or the space between it? Space between it. Okay, well my calipers don't get small enough. But they're all about the same, right?
Mm-hmm.
Okay?
QT.
So how many boxes is that? You can get really close, like that's just almost on the line. So we can go 1, 2 little boxes. How much is 2 little boxes? 0.04 times 2 is what? Is 0.08. Okay? We're going to measure the PR interval. Well, this one's just about perfect. Starts right on the line. And it's a whole box. How much is a whole box? 0.2. Oh, QT. QT.
Bless you.
That was dainty. I'm like, what? Everything explodes. QT. QT. Now you can leave your calipers spread like that, and you can come down here to a perfect line and go, oh, okay, that's so much easier to measure. So I've got 2 large boxes and what, 1.5 small boxes? Or 1 small box? We'll say 1 small box. So how much is 2 big boxes? 0.4 plus the teeny tiny one. Okay, which is 0.44. 44444. My opposite is 444. Okay. Now. Oh, look, we got it. Yay, 2 small boxes, right? 0.16. I'm going to argue with the book and say that it was 0.2. Close enough. If you get within 1 small box, I'm not going to cut your toes off. Okay? You get 1 small box either way. So if you came at this and said 0.12, yes, you get credit. Okay? 1 small box either way. QT interval, 0.44. 0.44, right? Now it used a different rate count and it sort of counted that one that's sort of there and said 58. Okay, you get 10 either way. So if you came at me and said that's 60, okay. If you said it was 40, okay. All right, we give you some leeway. Okay, so now we're going to measure the rate, right? I count 8. We count 8? 80? Okay. PR. Okay, it's the same. How much is it? 4 little boxes. 0.16. Okay? If it helps you to think of these as whole numbers and then just add the decimals at the end, you can do that. So if you just want to think of it as 4 and 20, just remember to put your decimals in there. That's what I do. It's like, okay, then just move the space back too, because it's a lot easier. I can do 4 times 2 a whole lot better than 0.04 times 2. Okay, I'm going to check regularity. Yeehaw. P waves. Doesn't help that the screen keeps moving. I'm trying not to touch it as much, but okay, everything marches out, so it's regular. QRS, I'm probably not going to go small enough for this, but okay, so I got 2 little boxes, 0.08. QT interval. got one big box and 4 small boxes. What's that come to? Oh, I heard it, 3.6. 0.36. So we've got sinus rhythm at 80. All the numbers are normal. P waves are there before every QRS. We've got good measurements. Sinus rhythm at 80. Okay, so this dude jumped from a burning second floor balcony. I would too. And he's complaining of back pain. I do that without jumping from a second floor balcony. Okay, are we regular? Well, that's just as pretty as pie, isn't it? I'll take it. Now, with this strip, you notice that there's a lot of happening there. Okay, he's hurting. Okay, he might be moving because his back's hurting. He might be breathing different than he usually would. That's called artifact. Okay, you might have just a little bit of artifact in there, but it's not enough artifact to block your P wave. You can tell where your T wave is. Nothing is hidden. I mean, that's kind of a little bit, but it matches the rest of them because he just had a little whopper jaw there, right? Another technical term. So what kind of rate do we have? 90. Okay. I've got 90. PR interval will be about the same. Okay. I got 4 little boxes. 0.16. QRS. I don't know if I can plug this one. Ooh, that one starts right on it. Right on the line. So I got 1 small box and a little bit. 0.06. Okay, because half of the small box would be 0.02. You see why I think of them as whole numbers. I just can't do the whole decimal thing until the end. Here's our QT. Almost 2 whole boxes. You could argue 0.36, 0.38 right there, right? They say 88, of course they do. All right, 8-month-old infant after a seizure. So what do we know about infants? Are their heart rates going to be the same?
No.
Not going to be the same. What are they going to be?
Faster.
It's going to be faster. So what kind of rate we got? I count 15, right? So about 150-ish. Is everything there that needs to be there? P wave, QRST, P wave, QRST, P, QRST. Looks pretty good, right? Are we regular? God, I hope so. Please don't make me code a child. Looks pretty good to me, right? Now, the numbers are still going to be the same. The measurements, regardless of adulthood, infancy, whatever. It's just the rate that's going to change and it's normal. So you're still going to have your normal rate there for PR. Your normal measurement for QRS, which is teeny tiny. Okay? Everything's still going to be the same. Just going to be faster. $150. All the parts are there. All the normals are there. That heart rate of 150 is absolutely normal for an 8-month-old. Okay, we got an 85-year-old man complaining of chest pain and shortness of breath. 85 makes me nervous. Uh-oh. Uh-oh. Whoops. Eek. Nothing regular there, is there? What's our quick and dirty count? 100-ish. But what are we going to do? We're going to stand there and count it for a whole minute because that ain't regular. There's nothing normal there. What are we missing? There's no P waves. Just doing his own thing. He's 85. Probably got atrial fib, right? Oh, well, of course they say 110. Anyway. 100, 110, like I said, 10 either way. Okay? That baseline is, there's nothing there that can be called a P wave. Because it's just twitchy. Whew. Whew. Eek. What we got? What kind of rate we got? 170-ish? Yeah? I count 17.
Mm-hmm.
Well, where's our P wave and where's our T wave? I don't know. I don't know. Where did it go? It's ugly, isn't it? It's going, Mommy, Mommy, Mommy. Yeah. Can I measure a QRS? Yeah. Yeah, I can measure a QRS. Is it going to be pretty? No. Eek. Go blue. Okay, so your QR interval is there. Is it measurable? Is everything else measurable? Not so much. Of course, they say sinus tach, but it ceases being sinus tach at 150. Then it becomes SVT. Ooh, hello. Sometimes I forget my ideas back there. Okay, so what have we got here? 80. Are we regular?
No.
Well, that one's kind of obvious, ain't it? Well, we got a couple. Oh, darn. Right? Doesn't march out. Do we see P waves?
Mm-mm.
Can we measure the QRS?
Mm-hmm.
Yeah. Can we measure the QT? Yeah. Maybe. Am I going to try? Yeah. What have we got? We got atrial fib, right? A 78-year-old man with shortness of breath. You may see these letters and numbers as telling you lead 2, lead MCL. That's just the angle that it's looking at from the heart. Are we regular? Let's measure up here. Oh, darn. Oh, crap. No. Not regular. Our rate we got. Got a rate of 70. Some people will get confused on these when you see 2 strips and count me 140. It's not showing me 12 seconds worth. This is still a 6-second strip. It's showing me 2 different views of the heart. Okay? So this is still just a rate of 70. Can we measure the QRS? Yeah. Yeah, it's measurable in both of them. When it looks like this, you just measure between the 2 edges, because we measure from where it leaves the baseline to where it comes back to the baseline. So we can measure it, it's just not great, because we're at 3 boxes, 0.12. Okay? AFib at 70. As long as he's anticoagulated, I'm not really that crazy worried about this one, because at least its rate is under control. Okay, we've got a 14-year-old adolescent complaining of chest pain. This is the kind that makes you run. Okay? 14-year-old should not have a heart rate that looks like that. How many we count? Can we count? It knocks me cross-eyed. You got what?
22.
You got 230? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22. 220, 230, close enough. 10 either way. We're not harsh. We're not here to eat you for supper. Okay, can we find anything to measure besides the rate?
No. QR.
We can measure the QRS. Eek, eek. It's there. It's tiny, but it's there. So this is SVT, supraventricular tachycardia. This is something that we have to treat immediately. Okay, same 14-year-old patient as the previous one. And this is after we gave adenosine IV slam. Oh, back to normal. Okay? Is it a pleasant feeling? No. Because his heart actually stops and converts back to a normal rhythm. I actually had a patient tell me, oh, I'm allergic to that adenosine stuff. I said, oh yeah, really? What's it do to you? Makes me feel like my heart stopped. Just where I'm grateful for masks, because underneath that mask I'm going, that's what it's supposed to do. It's like people that tell you they're allergic to epi. Like, you do realize your body makes that, right? I'm allergic to water. You are 75% water. No, you're not allergic to water. You're allergic to the stuff the city puts in the water, maybe. You're not allergic to water. So we were ticking along there. We gave the meds. We slammed the medicine in there. Generally, they want you to give adenosine through a central line so that it goes straight to the heart, because it has a half-life of like 0.5 seconds. And you push and slam a flush behind it so it gets there fast enough. And then we got back to a relatively normal. At least he's not ticking along, right?
So when you're in that type of rhythm, could you not do a vagal maneuver first to see if that?
They will try that first. Yes, they will try a vagal maneuver first. This tends to be a last resort.
Right.
Yeah. They may have you bear down like you're trying to poop. Hold your breath and bear down. If there is a provider present, they may do what's called a carotid massage, and they massage your carotid artery. That's why you always have to be careful when people are rubbing your neck, because they can accidentally, if their hands are too big, they can accidentally rub your carotid and make you pass out. Yeah. So, well, I worked with this guy. He was 7'2". Okay, so he had hands like Shaquille O'Neal. And, dude, he gave the best shoulder rubs ever. But you had to be careful that his fingers didn't come around and get your carotid, because then you were useless the rest of the day. Like, sorry, Ben gave me a massage. I'll be back in a minute. Oh, he had the best hands. Shoulder rubs. Okay. Shoulder rubs. Okay. Now, what does this look like? That looks like a saw edge to me, doesn't it? A sawtooth? That's called atrial flutter. Okay? It can be just as risky as atrial fib if it's not treated. So you can count the number of flutters and say, you've got 2 or 3, but no, it's just atrial flutter. We're not going to make you count it. So we can't really count PR interval. We can't really count QT interval. You can measure QRS. It's there. It's normal, but nothing else about it is normal. 1, 2, 3, 4, 5, see 80. About 80. So not horrible, but not ideal either. All right, what have we got here? What's our rate? Quick and dirty rate. 100-ish, right? Have we got PRs? Have we got P waves that we can find every time? Not really. That's how I look at them too. Do face like this. Hey, you can do that. Regular? Oh, Oh, okay, nothing regular about it. I can see my QRSs every time. They're there. Can you see a T wave every single time? Yeah. There's one. There's one. There's one. They're there. So we've got atrial fibrillation. Okay? Eek. I don't know what's happening along that baseline. Oh, I'm even making the sound, ain't I? This looks like sawtooth. Not very pretty sawtooth, but it's there. What's our rate, quick and dirty? 110. We've got flutter waves. I like strips that look like this, where it's a heavier line, where you can see. Got the pink color behind it. It makes it so much easier. When it's in black and white, it makes my eyes cross. If you are old like me or blind like me, and you want to bring a magnifying glass for the checkoff, you are welcome to do so, as long as it doesn't have the answers written on the handle. But I have had people check off with those little magnifying thingies. That's absolutely okay. Because some of us have astigmatisms, and it does make your eyes cross to look at all these tiny little lines squished together. Okay, what kind of quick and dirty rate we got?
120.
I heard 130 and 120. 1, 2, 3, 4, 5, 6, 7, 8, 12. Okay, so 120. What can I measure besides the rate? Can I measure the QRS? Yeah. Sort of. Yeah. Can we do QT? Oh, there it is. Okay. There it is. Just can't do PR, can we? So we've got AFib, rate of 120. Okay? 54-year-old dude passed out. What have we got?
60 beats.
Rate of 60. Okay? Is everything there that's supposed to be there?
Yeah.
Is it regular? Okay? P waves are there. All right. QRS is there, P wave is there, T wave is there. We've got a heart rate of 60. What's that make it?
Bradycardia.
No, if it's 60,
Normal.
it's normal sinus rhythm. Okay? It's not Brady until it's below 60. 59 and under. 59 or less is going to be Brady. 60 is sinus rhythm. That's the cutoff. 60 to 100 is normal. Correct. Now, I don't know how Miss Potter does this. Do you guys take lunch like right now? And take a break and come back in half an hour, or what? What do we do?
Take a break.
Just go straight through and just leave it.
Just keep going? Is everybody okay with keep going, or does anybody need to eat?
I gotta go train the main thing. I'll be back.
I'd rather you go see a man about a horse, but whatever. Okay, well then let's take 10 minutes and everybody go eat.